Welcome, you guys. Part 2 of our Becoming a Senior series. Today we're going to be cross-covering. It's going to be really fun. So, I'm going to include a meme in front of all of my conferences. So today is when your intern's getting hammer page and you're just slowly walking to your call room. Senior life is more fun. We'll learn a few cross-cover tips. Assess sick versus not sick, and then be appropriately fearless if you're taking action, which is easier said than done, but as a senior, sometimes you have to without any supervision around. And then just a few points about our cross-cover system here, right? You will have attending backup on all the wards months. In the ICU, at the VA, you also have the floor attending there to help you. The only place we really have no supervision in-house is at Denver Health ICU. Of course, the fellows and attendings are happy to come in whenever you need them to, but until they can, it's just 2 seniors solo. And then most of the time, you're sort of the second call for cross-cover, unless you're in the ICU cross-covering by yourself. So my first hot tip for cross-covering is being organized. And so I'm just showing an example of how I like to organize my sheet when I'm cross-covering. I'll have sort of the times for things I need to follow up on, the teams, and at the bottom I write down the sick patients that the team tells me about, so I have some idea of who I should be worried about. And then if I'm going to look up Mr. T's CBC, then I actually jot down the result, not on this sheet, but the handout that the team gives me. So in the morning, I'll just flip through the handout, see anything I wrote in red was stuff I followed up on, and just tell them about it. And it's really easy and organized that way. The second tip is, if you have time and haven't gotten paged already, try to see those sicker patients at the bottom at the beginning of the shift. Especially in the ICU, it's helpful to see what they're looking like, how comfortable they are, what their tele is showing, so that later in the night, if they decompensate, then you have an idea of what they looked like a few hours ago. And in the ICU, people change hour to hour, so it's helpful to know what they look like at the beginning of your shift. And then lastly, again, we talked about this with our managing multiple admissions conference, but here we also want to delegate, and one thing I want to remind you of is, just if you're going to go to a code or do a procedure, please give that cross-cover pager to your co-resident or an attending, or just somebody that can help you sort of triage any other pages that come in, because especially in the ICU, 2 people can be equally sick, and you want to be able to attend to that other person. All right, so let's get started. So we have Tyler and Jake today, who are our 2 seniors at Denver Health. So they have gotten an instant promotion. The admitting senior is busy, and so you're ready for a night of cross-cover. And you'll both sort of be the cross-cover person in this scenario. Okay, so the pager goes off, and here's the page. It's from your co-resident who's admitting, and they're like, hey, need you to evaluate bed 950 as a floor patient for a MICU transfer. I'm swamped. Here's the callback number. So seeing this page, you guys have a few options. You can look at some stuff in the patient's chart, or you can call this number back. Where do you want to start?
I mean, personally, I like calling back just right away and then bringing stuff up as we're talking.
Yeah,
if
absolutely.
you're going to transfer to the MICU, it might be nice to just get an update of how sick they actually are.
Yeah.
I have to second look at their chart, but just go see them before I peek through too much.
Cool, awesome. And then for seniors that are logged on and that are in the room, if at any point you have input on how you do things differently or in a more efficient way, please chime in. So, okay, so you call the number back and you get the floor cross-cover intern who's asking for your help. And they're like, hey, Jake, yeah, I got this patient here with cirrhosis, and she's just more hypotensive now, so I wanted to transfer her to the ICU.
Okay. Can you give me a little bit of backstory, how hypotensive are we talking? Has she or he gotten fluids?
Yeah, she's like 80s over 60s right now, and I just know that, the AHA says that anything less than systolic blood pressure of 90 is really scary, so I just am worried about her. She's admitted for SBP and is getting treated with antibiotics. I don't know if she's just getting more septic or what. And the team did sign out to me that I could give her some albumin if needed overnight, so I've already done that, but her pressure is still the same.
And do we have a baseline blood pressure when she came in?
Yeah, that's all in the chart. You know, I don't have it all written down here on my sheet.
Did primary say anything about what her blood pressures were during the day then, or?
Yeah, I think they've like been up and down. I'm not sure what to make of this one.
And her mentation?
She looked okay when I saw her, a few minutes ago. She just seemed a little sleepy.
Okay, well, we can take a look at her, but I would say that, you know, these people run at that a lot of the time, so let me just do some chart checking and we can go see her as well.
Okay, Tyler?
I don't know if there's much more I'd really ask. I probably want to go through her chart, like you said, and look at like some of what her pressures have been doing, and look at the rest of her vital signs as well. Maybe just ask a little bit more if like she's been lethargic or if like it's like different from what her baseline is. That'd probably be the only other thing that's on the note.
Yeah. So do you want to look at the chart now?
Mm-hmm.
Yeah. Okay. Do you want to look at just the brief sign out that's listed? Do you want to look at the vitals or labs?
I'd probably start by looking at her vitals.
Their vitals. Okay. All right. Here they are. Sort of talk through what you're seeing and how you're assessing her now.
I mean, it looks like when she came in, she was febrile and tachycardic, but was otherwise doing okay. Her blood pressure was a little bit soft. I don't know what she really was outside of the hospital, but she was a little bit soft when she came in, but it seems like they thought that she was stable from that perspective when she initially came in. And then the only other change I see is she's now having a little bit of an oxygen requirement. She's up to like 2 liters where she was on Humira before. But her blood pressures look fairly stable to me. Like they haven't really been that off from the 80s over 60s that they told us that she was at right now.
Mm-hmm.
Yeah, I would say the thing that concerns me the most is not having a reason for this oxygen requirement that we haven't heard about yet, and otherwise things look like they're getting a little bit better, and her initial vitals can all be explained by SBP.
Great.
So.
Okay, so not super worried about the blood pressure just yet. Do you want to look at the sign out or labs next?
We can just sign that.
Yeah, I think it's always helpful to like, as soon as you get called about somebody, have that signed out pulled up in front of you. For this patient, it might be harder because they're on the floor and you have to might go digging for it. But this might help you with, could it explain her oxygen requirement for any other abnormality you're seeing? Yeah, so do you think something in here could maybe explain her oxygen requirements?
Large volume ascites.
Mm-hmm. Yeah, so it's not uncommon for patients with cirrhosis, especially at nighttime when they lay flat, for that ascites to push up on lungs and have some atelectasis happen, and they can have some oxygen requirement, and it's not uncommon. Okay, do you want to look at labs, or do you just want to go see her?
Maybe labs. I feel like the labs would be helpful, especially for the creatinine here and stuff like that. Yeah.
And especially when you're getting asked to come see somebody in the ICU, it's helpful. Okay, so, oops, you're looking at the labs, but your pager goes off again. So, here's that next page, and you look at it, because it's important when you're cross-covering the ICU to not ignore pages, just look at them right away to make sure that it's not a 911 and you need to start running somewhere. So, RT's calling you from one of your ICU patients. Hey, the peak pressures are alarming in bed 254, please advise. I mean, this is a newer RT. They don't have a ton of experience yet. So do you want more info on this patient? Do you want to act and tell the RT to do some things, or do you want to not deal with this right now and just go back to the other patient?
I would call them back. I mean, this would be emergent. Yeah.
Yeah. So, okay, so RT's on the call now, and they're like, hey, just calling about this patient. Their peaks have been like in the 50s, and so I'm just wondering if you want me to do anything about that.
Honestly, I'm not really sure what to do with like the elevated peaks.
Okay.
I don't really know like what questions I would ask.
That's fair.
I'd probably ask them to get vitals and get an inspiratory hold and get a plateau, and then get back to me with whatever the plateau vitals are.
Yeah, so so she's like, yeah, you know what, we actually did that, the nurse was really helpful. The vitals have been pretty stable like all day and what they were before. And we did the inspiratory hold. The plateaus are actually really great. They're less than 30. It's just the peaks that are alarming. So what do you want me to do about that?
So I'd say make sure the tubing is all connected, make sure that they're not biting down on the tubing. And other than that, you know, maybe they're having bronchospasms, so we could try, like NEBs as well right now.
Yeah, great. Any input from Dr. King or Dr. Bowman or colleagues?
Oh, perfect.
Yeah, excellent. Okay, so great. So here, you know, peak pressures alarming by themselves is actually when the plateaus are okay and the vital signs have stayed stable, is less concerning to me. As Jake mentioned, peak pressures are really a measure of sort of the external circuit and the large airways in the patient's lungs, and sort of the global resistance of the system. And so checking to make sure that the tubing is all correct and there are no kinks in there is the first thing you should ask the RT. The next thing you can ask is, hey, you know, this patient was admitted for something that like reactive airways disease, then let's try some albuterol, NEB, or something to see if we can get these bronchospasms under control. And there's one more thing that they can do that would really help with this. Suction, yeah, so deep suctioning, because often mucus plugging will cause pretty high peak pressures, and so ask for them to suction the patient, do an albuterol treatment, and go from there. So, okay, so the RT's like, cool, I'll do that. Are you guys feeling okay about this patient for now?
Yeah, I would say maybe get back to us with a peak after you do these interventions.
Okay,
Again.
all right, I'll do that. Okay.
So one other thing I would add is just like Sneha mentioned, it's a newer RT, they like, sounds like they went through a lot of problem solving, but I always, if there's any patient I get called about that I don't want to lose track of, I'll try and give a specific reason to call me back. Of like, if the oxygen starts dropping, you need to go up on FiO2, or this doesn't work, call me back in half an hour or sooner. Just because I mean to go back and see this patient later, but if I get admissions, get a lot of other things going, they could completely slip my mind, and you could be in a bad place in the morning. So it's always helpful if you want to know to ask them to call you back for specific reasons.
Great, so Dr. Bowman gave the advice that in a case like this, or a lot of times when you're talking to RT, give them specific reasons to call you back, like, hey, please try this, but if you're going up on FiO2, or if the alarms are still going off, call me back in half an hour and I'll come see the patient. And then the other advice I'd give is, like, especially in a lot of these scenarios, our ICU nursing staff and RTs are really well-versed in what they do, and so when they call me, like, my reflex question I ask them is, what have you done so far? And it gives me a good idea of what I need to direct them to do next. So that's something you guys could have asked this RT right off the bat. Okay, no more pages so far, so let's go back to our last patient then, where we were left off. Okay, so here are that patient's labs.
I guess just looking through those, she has some hyponatremia, elevated Philly, elevated INR, so she probably has not great liver disease. Her white count's been improving and her hemoglobin's been stable, which is reassuring, especially if her pressures have been low. So I'd say that they're fairly reassuring labs.
Okay, and then one thing I didn't show you was nurses have a protocol where if they see a pressure below a certain level, they're going to reflex to a lactate. And so they got one in this patient, and it's 4.
I feel like I'd probably trend that, but a lot of liver patients don't clear their lactate very well, so it could just be she has a higher lactate at baseline. But I'd probably trend it.
Yeah, so that was supposed to be a trick. Danny did a great lecture on lactates on Tuesday. Go watch that if you need more information, but this patient is unlikely to be clearing her lactate and may just have a high one. So either look at what it was on admission or trended, but again, we're not too worried about it. So you gotta go see this patient because you're being asked to evaluate them. So we're at the patient's bedside now. And so what are the things you're gonna look for to determine whether she needs a transfer to the MICU? So I'm the patient, so ask me questions, ask me whatever you need to.
Okay, I would think I would start with like A&O,
Mm-hmm.
and make sure they're, you know, breathing well, they don't have any obvious bleeds, their stomach isn't horrifying and super tender, like that. Those would kind of be the big things, and maybe repeat a set of vitals if you're in the room.
Yeah, so let me answer those and then see if Tyler has any questions. So the vitals are exactly what they were. She's still in the 80s over 60s. She's ANO times 3. She says she just, like, it's coming up to her bedtime, so she's feeling a little sleepy, but answered all your questions, right? She does have some asterixis on exam. Her belly, while large and somewhat tense, isn't, like, rigid and scary. You can still push on it. Yeah. I think those are all the questions.
And no, like, melena in the bed?
Yeah, no melena in the
bed.
bed, no obvious bleeding from any of her IVs or anything like that, and she seems to be breathing comfortably.
I might just ask, sometimes patients know what their blood pressure runs at home too, so I might just ask her if she knows that, but.
Yeah, so she says, yeah, you know, whenever I go see my outpatient doctor, everyone always gets scared about my pressures, but my liver doctor told me, that this is just what happens to my body, and it's generally like 80s to 90s.
I would say like all of that is fairly reassuring in general. The exam is reassuring, her labs are reassuring, this is where her blood pressures usually are.
Okay, everything's reassuring. So what do you want to tell, the floor team?
I'd probably just have them keep an eye on her overnight, make sure things aren't looking worse, but that she can probably stay on the floor.
Great, so this patient can stay on the floor, and you get calls like this often, and so you guys appropriately kept her where she needs to be after doing an assessment. Great. Okay,
Can I add one more thing?
yeah,
Sorry, I think the one other thing, and it's like, they did right by probably giving her the option in the first place, but she's got this large volume ascites and already on 2 liters from room air. So I would just say to the intern, like, feel free to call me again, maybe try and avoid giving any more fluids, and if you do, watch her oxygen closely, because these patients are they're very hard to get fluid off of as well. If they need it, they need it, but seems like she's doing well, and so we don't want to, like, reflexively give fluid that we can't get off.
nice. So Dr. Bowman is making a point for liver patients especially is to not give unnecessary fluids. They do tend to accumulate and can sometimes have worsening oxygen requirements, especially like this patient's already having. So just call the MICU if you're feeling like you're uncomfortable with the low blood pressure, or call your senior on the floor and they can help you assess. Okay, cool. So the RT calls you back and, the RT calls you back and is like, hey, the peak situation went fine. There was a lot of mucus and I got all that out and the peak pressures got better. But now I'm calling because that patient just has a ton of vent dysynchrony, and can you come see them? So tell me what you want to do. Do you want to look at the reason why they were admitted? Do you want to look at their vent settings, or do you just want to go see them?
I might at least ask, like, if they're still, like, how their oxygenation and things like that are going, but they're having all this synchrony.
Yeah, so she's like, you know, yeah, I've been, like, messing with the vent quite a bit here before I called you, and their oxygenation is worsening. Now they're on FiO2 of 60 from 40, and, but I've changed some other settings, but it is just not getting better.
And then I would try to clarify what the desynchrony is. Is it she's stacking breaths, she's over-breathing the vent? I think there's a lot of ambiguity to that.
The RT is not exactly sure. It's just like everything's alarming at different times.
Usually they'll say, like, I tried going up on the respiratory rate, because I thought maybe that she was, like, hungry with the hypoxia. Didn't help at all. I tried doing to, like, a patient-triggered mode, not helping. I just cannot get the vent to line up with the patient.
Okay. And I guess I would also ask them any concerns with, like, under sedation, like, she feels like she's in pain.
Yeah, so they're like, yeah, you know, this was an issue all day, and we've been coming up on the sedation all day.
Okay. I think at this point I would look at the notes and look at the most recent counseling.
Yeah. So here's the sign out that you got. This is a 6-year-old man who was admitted for COPD requiring intubation. As I already said, that he's had increasing sedation requirements due to vent dysynchrony all day, and he's occasionally auto-peeping. And deliberately, I'm giving you less information than we were giving in the admitting patients, because this is just a few cases here, but during this time, you're getting like all these other random pages about diets and this and that, and so you really don't have much time to look at the chart, and so this is the amount of time you have to look at stuff. Okay, and here are the vent settings. I'll reveal the new information for you. And so let's pretend now you're at the bedside, and the current vent settings that you're looking at the vent are basically similar to what they were an hour ago, and the RT says that they've tried, really a lot of different modes, but nothing seems to be working right now.
I guess I would say, this person's oxygen is substantially worse now. I would probably honestly get a chest X-ray in them, just to make sure we're not missing, unless I had one like very recently. But I would try at least going up on the PEEP for this person.
They tried that. They like mess with the PEEP up and down. Nothing's working.
Yep.
They do like an expiratory hold or something. For like, isn't that what you do for like auto peeping?
For auto peeping, yeah. And they're like, yeah, we looked for auto peeping, and it's fine. I messed with the I to E ratio and the PEEP and everything to adjust for that.
Yeah, I would honestly in this situation, I'd probably just go all the way up to 100% on the O2 if she's, maybe it's not terrible. I don't know, I get a chest X-ray. That's what I would do to see the patient.
Okay. Anybody else want to do something else?
I think you already talked about sedation, and it sounds like they've been going up on sedation. So I think it would be worth you asking the nurse and going yourself to decide how sedated this patient is, to get an idea of what might be driving. Is it like discomfort, or is it a respiratory drive that's causing this synchrony to a certain extent?
Yeah. And so the nurse is with you at the bedside, and they're like, yeah, we have gone up on the fentanyl all day. It's pretty max. I don't feel comfortable giving more. They're on propofol, and we're like really sort of as much as we want to give of that, since the patient's been on it for a few days. We've been doing PRN Medaz, and it's just like not helping.
You get paralyzed. You're pretty much exhausted.
Yes.
Yeah.
Great. So that is really the next step with this patient, because it sounds like they're telling you, hey, we have tried everything in our arsenal. Seems like the day team has been trying things in their arsenal, and even with like a lot of sedation, good pain control, because often pain is something that triggers dysynchrony quite a bit, so you want to make sure you have good pain control. Sometimes patients are hungry, and that's why they have dysynchrony, and so making sure they're getting tube feeds, and checking their belly to make sure that's not really distended, or you're dealing with something like abdominal compartment syndrome, so doing a good exam. And then beyond that, if you have good sedation, like really the next step for these patients is to paralyze, take over control of their diaphragm, and help them breathe that way. So great. All right, onward. Okay, pager goes off again, and this time it's another ICU patient who just self-extubated, and now their heart rate is 158, so please come evaluate *1. Lots of options here, so you can call the nurse back, you can look at the brief handoff, vitals, and some other information, EKG.
I think I would just go to the bedside.
Yeah.
Bedside,
Oh,
They're calling you, so you're like, okay.
Yeah.
All right, I'm going to the bedside. Okay. You're at the bedside. What do you want to know?
How's their breathing? I guess first of all.
Well, their breathing looks okay.
Unless their heart rate, I'd probably take a look at their tele and see what that looks like.
Okay. I'll show you the tele if you want. Is that what you want, Tyler?
If I'm in there, I'd probably look over at it.
There it is. They actually printed a strip for you, and it goes from left to right, top to bottom.
feel like it's hard to say if I'm seeing like P waves on that like bottom part or not, but I feel like there are P waves coming before all the QRSs. But it does look like it came on like fairly suddenly as well, which isn't great. If it was more like a sinus thing, I would expect it to kind of like build up to it. I probably want to know like what their blood pressure looks like now as well.
Any other comments, Jake, on the strips?
I mean, it looks like Todd said SVT probably is narrow complex, which is reassuring. Some type of SVT and blood pressure sounds like a great idea.
Good, yeah, so narrow complex, supraventricular tachycardia. Seems to be a pretty abrupt onset where the patient was going like, 70s here, and then all of a sudden with one beat, they're going faster and faster. Okay. So, let's just go back. Here are their vitals.
Their blood pressure looks, slower than when they came in, but it's not like concerningly low at this moment. They do look like they're a little bit febrile otherwise. And then the heart rate, but 30.
Yeah, Dr. Bowman has a comment.
Yeah, I throw out, like, one thing, anytime I hear someone is, like, self-extubated, the first question I find really helpful is when were they intubated and why? Because that helps me frame, like, is this someone who was intubated for COVID 3 days ago and is likely gonna need a ventilator for a long time, so I need, like, anesthesia or whoever's gonna be doing tubes coming? Or is this someone who was intubated for sedation with alcohol withdrawal yesterday, waking up, and maybe it's gonna be okay, and I should go see before I call the people who are gonna tube them. And just to kind of like, yeah, it kind of just changes my workflow, because I can't do an intubation by myself, and I need the people there who can, kind of like my biggest concern.
Nice. So Dr. Bowman says, for people who self-extubate, it's important to know, hey, when were they intubated, why were they intubated, and what is the likelihood that they're about to need intubation again now? I think that, in real life, this won't be so much the case, but I think one pitfall you guys are falling into is not looking at the patient handoff. So I'd encourage you just to look at that handoff, like, real quick. And in real life, you'll have that piece, like, all those sheets with you. Even while you're walking to the bedside, you can just look at it and read at it. But here, it's a little different, so I'll just show that to you, and then that might help you understand sort of what Amelia was saying, right? So this patient is 44 years old, has polysubstance use disorder, and has some cardiomyopathy, admitted with methamphetamine intoxication, requiring intubation. And the team here says they suspect they can extubate soon, and that they need a podiatry referral for a foot wound that the patient has.
Would be more helpful if they just suspect will extubate soon. That would be the perfect answer.
Yes, suspect will extubate soon. So let me ask, you guys may have done Denver Health ICU as interns, but for those of us that have done it as seniors, what could the team have done to prevent this?
The fast track
Yes.
extubation.
Yeah, so they probably forgot to put the fast track extubation order in, and so at Denver Health, they've purposefully designed a system where patients that come in often with intoxications and get intubated for airway protection, you put this fast track extubation order in, and then the nurses and RTs take over. They'll go down on the sedation as appropriate, and then when the patient's ready to extubate, they'll be like, hey, I'm extubating, and then they don't need your approval to do so, and they just take the tube out. And that would have been safer for this patient rather than self-extubation. All right. Okay, what do you want to do now?
Well, there's a picture, looks like, so what am I thinking, we'll get his foot now with this fever?
Oh, that is not the foot picture.
Oh. I guess I'd be less worried at the very least now about like needing to get like, they said like anesthesia involved or re-intubate, but the SVT coming in with like this foot wound that I've never seen before, I wouldn't mind taking a look at that and seeing if he's on antibiotics as well.
Okay, great, what else?
I'd probably get an EKG as well. I I don't know if we necessarily need it, but we kind of know that we're dealing with like a narrow complex, so we can take a look at the EKG. And then his pressures are stable, but we should still probably try to get him out of the rhythm. I think with the narrow complex, you can just start with like adenosine.
Yeah, so let's look at an EKG. I think that, give your guys' input, since y'all are here, but, it's difficult sometimes for me to approach the sudden onset tachycardias in a patient, and I really think about, showing up at the bedside, seeing how stable they are, and if I feel that they're stable, I do try to get an EKG because I want to see if I can identify the underlying rhythm, which sometimes is easier to do on a full-blown 12-lead EKG than it is to do on a rhythm strip like that. So I think that's a good thing to do here, which the patient seems fairly stable. If they're awake and breathing okay, let's get an EKG, see if I can diagnose the underlying rhythm. So here's that EKG. Does this help? It's just whether it helps or not.
I mean, it looks similar. Some of the it looks similar to what we were seeing on the telly.
Yeah, not super helpful. Still narrow complex SVTing, with probably a left bundle here. Okay, so Tyler wants to do adenosine. Tell us, Tyler, how you want to administer that.
I think you start with 6, and you go. If they have a peripheral, you start with 6, and you push it, and then flush immediately after. If they have a central, you just do 3.
Good.
And then see what happens.
Yeah.
And you put like the EKG leads on like as you're doing this, so you can like actually see what's going on.
And then, Amelia's showing you what else to do. Pads. Yeah.
To fix it in case.
The heart doesn't restart.
Yeah.
Yeah, so you want to get pacer pads on, you want to get pads on to pacer or defibrillate, either way. And then make sure you have a rhythm strip going, and then you're going to push it in different doses, whether you're pushing it via a central line versus a peripheral line. And so here is what happens. So you tried 6, nothing happened, so you tried 12, and what do you see?
Well, there's a beat at the end, which is good.
Yeah. They came back.
5 seconds that felt like 20.
Yeah, so everything happened that we thought it would.
Yes, what rhythm is it?
Well, they're in essentially asystole for whatever time that is, I don't know.
Yeah, but what do you think the underlying rhythm might be? What are these?
Those 3 waves, so it's flutter.
Yep, so sawtooth, where's my arrow? I can't see it. So all these sawtooth waves are that this patient is in flutter. There were clues to that on the EKG, but I think are extremely hard to find. Like, if you march out the P waves, they're beating at 300, and the QRSs are at 150, and so it's 2-to-1 flutter actually in the EKG. But that's like, I can't really tell that looking at an EKG like that. And then the other thing that sometimes can give that away to you is just remembering that, like, if there is variable conduction flutter, then it'll be in like increments of 300, right? So it'll be 300, 150, 75. So this person jumping from their normal to like all of a sudden 150s should sometimes clue you into like, this could be flutter because they went like just straight this 150, a beautiful number, right? For 2-to-1 flutter.
I wonder if they were 3-to-1 flutter. On arrival too, yeah.
Oh, they may have been, yeah.
Yeah, that's anytime I hear a heart rate that's about 150, a flutter, it like is the first thing I think of, just because, and then especially if you're there and it jumps up by increments of like 25, 50, 75, I assume it's flutter, if I have to make an assumption.
Yeah.
ADRT and AVNRT also usually 150. Yeah.
Now, I would be very pessimistic about doing this, and with success than someone who just self-extubated. But just a friendly reminder, you can try Valsalva maneuver and stuff to try to slow the rhythm down. Sometimes you can break SVT, but other times you can just slow the rhythm down and you can actually see what you're looking at before you push the adenosine. As fun as it is, not for the patient.
Dr. John is saying, try Valsalva maneuvers. We're moving away from carotid massages now, but having the patient blow in a syringe, things like that, bearing
Pushing
down.
on their belly.
Yeah.
Just like push down on their belly.
I guess pushing down on the belly, yeah, to see if you can break it. Very often the nurses have tried stuff like that for you, and then call you if they're like, oh, it's not break. You know, I tried this, it didn't break. Okay. Oh man, the night is getting long. Here we go. Oh, sorry. I'm gonna have to do a couple clicks here. Come on, just go to the next page. There we go. Okay. Last page. Remember that patient we first saw? She just vomited a liter of bright red blood. 911, that's a real 911 page. You're like running to the bedside. Okay, so you're like approaching the bedside because you're not gonna look at the chart at all for this patient. What do you want to do when you're there?
So I feel like in these situations, like literally just walking in the room tells you like half of what you need to know. Like, is this patient breathing? What's their respiratory status? You know, what is nursing doing? Are they getting IVs set up for this patient? Is the patient mentating at all? And then from there, you can kind of get stuff started.
Yeah, that's great. So, you know, just assessing at bedside, and at some points having a fresh set of vitals will be helpful. But of course, like our visual assessment is really helpful here. So the patient, you see she's holding like her vomit bag, and it does have bright red blood in it. It's sometimes helpful actually to confirm what is the color of whatever excrement we're talking about. Sometimes it's a fake out, but in this case it wasn't. The patient is still awake, and she's like, actually, I feel a lot better now that I threw that up. And she's answering your questions still, and the nurses are getting vitals done. She already had 2 big peripheral IVs for antibiotics and albumin and stuff. That's where we are.
I know we can send off the CBC, but she just threw up quite a bit of blood, so I'd probably give her some back. I'd probably just start with, I don't know if I'd start with like 1 or 2 units, but I'd at least give her some blood back right away since she did. And then I'd probably bring her down to the ICU at that point. It sounds like she's breathing okay and doesn't need to be tubed or anything like that, but I think she probably needs closer monitoring now that she just had large volume hematemesis.
Okay.
Yeah, I would say, you know, I actually saw that patient like this with Sam like a month ago or something like that. Sam taught me a lot that day, but it was like,
teach us today.
yeah, but you know, this is someone that if they're feeling that well, if vitals are okay, if we have a hemoglobin that was like, you know, normal and not already super low, maybe step down would be okay for them. But I think a great line I heard from, I think it was Dr. Messenger at Once in Cards is like, if you're thinking about 1 unit, you should just give 2 units. And so I would like to get everything kind of, I would order probably 2 units already, make sure there's a consent in as well. And yeah, I think probably appropriate for at least step down at this point. I don't know the vitals yet.
Okay, I'll show you the vitals because they're getting done, so they're coming to you live. Okay, so you guys have done a lot of great things about, you know, like a massive GI bleed type scenario. First, let's just clarify, what kind of bleed do you think she's having?
Variceal.
Variceal, right? So you have specifically clarified this is a variceal bleed. We have few things to sort of tell us that that might be the case. A, she is infected. B, she has massive ascites, so a lot of portal hypertension happening. C, she's been getting some albumin here and there. So again, when we give these patients intravascular volume, risk is always higher to cause that to back up and for it to become a variceal bleed. So now we're worried she has a variceal bleed. You did great work, so you made sure that she had good access, which is our number 1, and did the ABCs before that even. She looks okay, she's breathing okay, she has access, we're thinking we gotta get blood, so if she's not consented already, you're consenting her, and this can be an emergency consent for her. You know, hopefully she got typed and screened, but if not, that's something you're gonna have to like really do fast, unless you think you might be doing massive transfusion protocol, in which case they'll send up whatever good blood that she can get. So now onto the topic of where she goes and whether she needs intubation. Any other thoughts on that?
I think there's just like thinking too about a couple things that we should be putting in those IVs other than blood.
So we need
You know that.
Loading
just,
dose,
like,
yeah,
sort of
loading
thing.
dose PPI, ceftriaxone, octreotide.
Good, yeah.
Yeah, and then Rainbow Labs essentially on this person.
You're sending Rainbow Labs, okay, let me close that, so yeah. So basically, I was gonna say, like, what do you wanna do now? So, type and screen, if, for later, ordering some blood, Rainbow Labs, great. Octreotide, she's already on antibiotics, so that's fine. And PPI, great.
And then also like a liter or two, I mean, she's hypotensive,
Yeah.
more hypotensive, so I'm assuming it won't be 5 minutes worth of blood, so there'll probably be more,
Yep,
so.
so get some fluids wide open now, okay,
And I
that's
think the
good.
other important thing on the vitals, one of the most sensitive things for blood labs, if you go in and there's some blood, but a lot of it's on a sheet, and you really can't decide, like, was this hematemesis, is this volume significant? The fact that she went from a normal heart rate to tachycardic, tachycardia can be one of the first signs of a GI bleed, so if you're thinking about a bleed and someone's heart rate was normal and now up, that can be enough for me to be like, okay, we need to do volume, we need to get something.
Yeah, tachycardia, one of the first signs of, hypovolemia, and so in this patient, we're giving volume back, great.
I think that GI bleeds are a huge spectrum. Not everyone who vomits blood needs to go to ICU. The variceal bleed is about as fast as a GI bleed gets, outside of maybe like an ulcer that erodes into an artery. And so when I think about like where to put someone, I think, do I think they need to be intubated? If yes, obviously come to the NICU, or if high risk for intubation, come to the NICU. And then do I think GI is going to scope them like now? Because if so, and it's not daytime, the endo suite's not open, and they're going to take them to the ICU.
So Dr. King, actually, we'll come back to the interns. What do you guys wanna do next?
We already got like blood going,
This is all
extratide, all that
happening,
fun
yeah.
stuff. Probably call GI at this point,
Yeah.
and have them come evaluate to see.
Yes, the GI fellow is of course also worried, just like you are, and like, I'll be there as soon as possible. In the meantime, they do want you to do some other things. What could you imagine those might be? We've already talked about this. So this is a patient that does need intubation, because they just had a lot of blood come out, and we haven't done really anything other than give some octreotide to help with this bleed. So the concern is that that varix is still gonna keep bleeding, and while the person is trying to do the scope, there's gonna be a ton of blood, and they're not gonna be able to see what they need to see. So these kinds of patients do need intubation, and I had like the exact same scenario happen to me at Denver Health. The ED called me to come see this patient they were admitting to the MICU, and I walked down there, and as soon as I get there, he like vomits a liter in front of me. And so then my next direction to the ED was, hey, can you please intubate this patient before they come up, because I know GI is gonna wanna scope them right now. What's the other reason this patient needs intubation? Say a GI fellow is like 45 minutes away.
Probably airway protection.
Airway protection, yes. There's another intervention you can do, before GI gets there.
Like the Minnesota
Yes,
tube.
Minnesota tube. And so most Minnesota tubes need the patient to be intubated before, and so a couple of reasons that the intubation in this patient will be helpful. So while she's awake and still able to talk with you, that's something to discuss, which is that, hey, I think we're gonna need to put a breathing tube in for these and these reasons. Is that okay with you? And if so, call the Palm Fellow in as well, so that you can do one tube, one after the other.
So who will put the Minnesota in, or like, cause we can't,
Whoever,
right?
like, if the patient is, if like this patient is like in the NICU at Denver Health, it's not infrequent that you get signed out on someone who came as a GI bleed, and they say like, they were scoped today, they think they got the varices, but they're still pretty hypotensive, and we're worried they may open up again, so there's a Minnesota at bedside. And it is basically, if they have hematemesis, it's a whole process to put a Minnesota tube in. It has to be on ice for a period of time, but you basically call the GI fellow, call X-ray, and put the Minnesota tube on ice, and like, if the patient is actively hemorrhaging, trying to do it is better than just watching and have nothing.
The Palm Fellows can do it, the GI Fellows can do it. Tomorrow, I almost had to put one in there like a few weeks ago because no one was answering their phone, but she ended up calling someone from the ED to come help.
Yeah,
Yeah,
I was
the
gonna
ED.
say, I would swallow my pride. I would call, if I felt really uncomfortable, I would call the emergency room and
Yep.
say, I have someone actively exsanguinating. Do you have someone down there who can, I'm alone up here, can you come help me do this? If they wanna laugh about me later, they can do that.
yeah, but I think the Minnesota is one where I would definitely call the ED
Yeah.
and go from there, yeah. Okay, this is not pertaining to this case because, we are basically done, and we'll do a summary here in a second, but, what do you do for patients who are having respiratory decompensation and the palm fellow is not gonna be in for like, what, 20, 30 minutes?
Like, that you think needs to be intubated?
Yeah.
Call anesthesia, or
Yeah, you can.
It's a busy night, like you're at Denver Health and there was a polytrauma on the highway, anesthesia is in all the operating rooms and no one can come right now.
And you're attending.
You're at
Yeah,
Denver
you're
Health.
busy.
Everyone is wanting to.
By himself.
Then what oxygen support did they put in? They were on room air and they kind of decompensated quickly. They're going up, I mean, we're doing the new like heated high flow with a mask, which is made up, but their oxygen is still going down. There is something you can do.
just like the nasal or oral.
Yeah, so getting something that's kind of, getting a definitive airway,
Yeah,
and then,
bagging.
Yes, something that I always forgot was a possibility, and I'm like, what's the pump fellow's not here right away? And it's like, you can just bag the patient. So just stand there, put their chin up, and sometimes you can have an oral airway, and if you need to, if you think there's edema and problems like that, or their tongue is too big or whatever. But yeah, just stand there and bag the patient until the fellow gets there to intubate. You know, in these bleeding scenarios, that's like not great and helpful. But I'm saying like in all the other scenarios, remember you always have bagging to fall back upon when you're by yourself.
Yeah, if you see like a red splash.
Yeah, you're like,
A bad situation.
Okay, so, busy night tonight. We had a patient with cirrhosis, one fake call about the BP, which can happen sometimes, but one real call about their hematemesis. And so you guys call our Pullman GI fellows. In these cases, like, have somebody with you, your intern, your co-resident. Like, I was with one of my co-residents at Denver Health when this happened to me, and I was like, Doug, you gotta get down here. Please help me coordinate this care, because I alone can't be calling all these fellows and seeing how the patient is doing. We had vented patients. Often you get lots of troubleshooting calls. RTs are excellent, and they'll have done a lot for you already. And you can always call the pump fellow and like run stuff by them, and they can give you some tips that you may not have thought of. And then always focus on sedation, pain, and comfort, because those are a lot of the reasons that vent problems are happening. So if the patient is adequately sedated, you can control the vent a lot more. And then tachycardia, hypotension are also very frequent calls. For tachycardia, the advice I have is, number one, making sure the patient is stable. So going to the bedside and making sure they're mentating okay and that their blood pressure is okay. And then if that's the case, you have time to get an EKG, to check the tele, do all those things deliberately. And then the other advice I have is always just put the pads on. So have the code cart come by and get the pads on, and then you have more time to like tinker with stuff. And in case the patient decompensates more, you just shock them. And so that's the advice I have, and what I commonly forgot to do when I was stressed out in this scenario. Cool. What questions do you all have?
For the, like, tachycardia patient, if you're like, you've done the adenosine and nothing's like converting and they're still, like, even after, like, when you're shocking, or should you be like calling cards at that point too, or calling somebody else?
Yep, yeah, preferable to call cards before you shock. Sometimes you have to just go ahead and do a synchronized cardioversion, there. It's a tough scenario because you're like, well, I don't personally know, like, how should I sedate this patient before I give him this shock? Like, should I give him sedation? Should I just shock them? I mean, like, do you have answers to this? Because I don't.
I mean, if you don't have a heartbeat, I'm gonna shock you.
Yeah.
And it is, I don't know either. I think what I would say, like, to a lot of, like, all of these calls, my first question when I get a call on an unstable patient is like, what's the worst thing that could be happening and can I deal with it? Like, if it's someone who's coding, like, yeah, I'm the person who would have to deal with that and I don't need to call someone else. But when you're going to the GI bleeder, being like, well, if they're hemorrhaging, I'm gonna need GI, and like maybe even have the pager ready on my phone to call if I get there and it's gone, or you're getting to, like, you're going to the room and they extubated and they're likely to need to be reinstated, ask the nurse to call anesthesia as you go in. Just trying to anticipate like the things you aren't gonna be able to deal with, because it's getting that ancillary support that often like stalls care and causes the delays that make everyone really, really uncomfortable.
I think also the sedating was shocking. You just have to yourself how much time you have and how available is sedation. Like, usually try to sedate people before you shock them, but I had, like, as a mixed resident, had to respond to somebody on the floor with tachycardic and hypotensive, so like 60s over 30s, and I'm not gonna be able to get sent to first set on the floor within a matter of seconds, you just do it.
Yeah, I've had at least a couple NICU attendings where we've shocked them, and I was like, all right, I'll give them Versed and then we'll shock, and then they're like, let's shock, and then give Versed.
And then before you.
Because if you give them the Versed and Penta, and then they're like, they bottom out and they code.
I know. Or their breathing gets worse, and you're like, now I have like, two systems are going down.
And this is
I think
absolutely like based on a patient population, I think, but I think the only patients I've had to shock were vets, and both of them, I was like, I'm so sorry, this isn't gonna feel good, and they're like, I'm fine. So like,
Yeah, adenosine also doesn't feel good, but I don't know if you guys know how many times you've pushed that, but, I've pushed it a few times now, and the patients feel awful. They're like, oh, I feel like I'm dying. I'm like, you are dying.
The sting